Our final presentation of this part of the morning is from Dr. Mucha. It's called Concussion, the Eyes and Ears Have It.
Sorry, it's a pleasure to be here. I'm going to discuss things a little bit differently, going a bit off of what Dr. Collins talked about as it relates to these profiles of concussion, which we very strongly believe in our program, and dive a little bit deeper into management, particularly management of the visual and vestibular circles that you saw. So I'm going to discuss those as well as hopefully share with you a little bit of options or ideas of things that we do to not only evaluate but to treat these particular conditions. All right, so if you consider a sports play, go ahead and roll this video.
He scored already. There's at least a point on here. He's got a goal instead.
So as I understand, this is hurling, right? And that's Galway, right? They're the red team. And that's a very nice play, a very nice goal. So we'll come back to this a little bit later, but I want to use that particular play in the context of how do we look at visual and vestibular issues, because they're key to what that man was able to do on the pitch there. So vestibular and ocular trajectories or profiles is what we'll follow along with here. And the significance, and Mickey talked about this a bit, but these are very common presentations after a concussion. In our studies, we see that up to 60% of patients are exhibiting some type of vestibular or ocular type of symptom after a concussion. But probably more importantly than how often they're presenting is that we are seeing that these issues are part of those patients who are taking longer to recover. And that's important, of course, because we don't want to direct resources or time or energy to conditions that are going to recover without much intervention. It's these refractory cases or these problem cases that we want to spend our time and energy on. And I think that what we found, especially early on, is that not many people know how to even look or identify these problems. So assessing what visual and vestibular problems occur after a concussion is critical. And then, of course, what is the treatment that we apply? So Mickey spoke a little bit about it. One of the tools that we developed fairly recently was this VOMS, this vestibular and ocular motor screening, which we find very helpful because it's a very low-tech, short-time process for being able to quickly identify those most common things that we find after the injury. So it's a brief 5-minute clinical test to look at the common things that we see in the vestibular system, which are pursuit, saccade, impairment, or pursuits, saccades, and convergence problems, as well as the vestibular system issues that we see commonly of vestibulo-ocular reflex involvement and visual motion sensitivity issues. And what we know is on those quick screening tests what predicts problems, and that would be positive findings, which is symptoms being provoked, or near point of convergence measures, which are receded beyond 5 centimeters. And we use this in combination with other tests. So this VOM screening can be really an effective tool. And again, it's very easy to do so that you don't have to be a neurologist or a vestibular therapist to do this. You can be any front-end clinician, an athletic trainer in our world, a primary care physician, a neuropsychologist, anybody who might be seeing this patient and trying to create a screening process to be able to identify what type of concussion is happening. And I'll show you some video of it. So first, though, and I apologize for those of you who really understand the vestibular system, but I have patients come into my clinic all the time, and that's the first question they ask is, why am I coming to vestibular therapy? They often can't even pronounce vestibular therapy, so I think that it's a good question. So I use this analogy that your vestibular system is like a gyroscope. Your inner ears act as kind of that sensory mechanism to determine motion, but it helps to orient you to where you are in space. So you have 2 of these in both inner ear, and then that sends signals into the brain. However, I realized when I say gyroscope, a lot of the kids still have no idea what I'm talking about. So then I have to use this analogy, that it's your internal GPS system, and then the light bulb goes off. So what are the components of the vestibular system? It's, as Dr. Collins said earlier, we have the inner ear as part of it, as well as brain function or brain structure. So we're talking about the sensors in the inner ear, the semicircular canals and the otolith organs, but it's also about what they connect to centrally, parts of the cortex, thalamus, cerebellum, etc. But more importantly, again, people care about, well, so what does this do for me? And there are two main functions in your vestibular system. One is to be able to stabilize your vision. So as I'm talking with you all, I'm moving my head side to side, I'm able to maintain my stability because I have an intact vestibulo-ocular reflex. The second is for balance control, and you use your vestibulospinal reflex to help maintain balance. So those are the two big functional ramifications of the vestibular system, part of also how we test for it. So symptomatically, our patients who have vestibular problems are going to complain about all of these, or potentially all of these symptoms. Dizziness is a big one, and I think Colin had talked about earlier, his son, when he had a concussion, you said that the first symptom was that he was dizzy, and we already know that that sometimes is an indicator that maybe this is even going to be a protracted recovery in some cases. So dizziness is probably the #1 indicator of a vestibular problem. But sometimes it's more subtle than that. Sometimes it's more of a general symptom of maybe being a little motion sensitive. Maybe it's being bothered in busy environments so that you're a bit uncomfortable in the school hallways, like this picture here shows. You just don't want to be where there's a lot of movement or things going on around you. We find that patients can have new sensitivity to other visual environments, such as heights that they didn't have before, tunnels, bridges, things of that nature. They may also just complain about overall just feeling that their balance isn't quite right, or they have a sense of disequilibrium, something along those lines. But it's often hard for patients to even describe what these are, so that's why it's so important for us to do testing to know. So when patients have problems in their vestibular system, there are basically 4 ways that they present in the concussion world. Now, this is not the way, there are many other ways that vestibular problems present in the general population. Many conditions that aren't unique to concussion, but these are the things that we see most frequently in concussion. So one is we see problems with that vestibulo-ocular reflex, so that gaze stabilization mechanism. Second is we see problems with visual motion sensitivity. So with a lot of visual complexity in the environment, we see problems with processing that. Third is we'll see balance impairment, and fourth, we may see benign positional vertigo, BPPV. And I'll go into each of these. So the vestibulo-ocular reflex, as I said, has the function of us being able to stabilize what we're looking at as we are moving our head. It's something you take for granted completely. You would never think about your vestibulo-ocular reflex as you're going through your daily life. Your VOR is kind of an assumed thing. It's kind of like your heating and air conditioning systems at home. It's all good until it's not working. When you have abnormal VOR function, it might be like the slide on the right, where you have some impaired stability in your visual function. Now, this is going to happen most commonly when you're in motion, when you're more active, when you're more dynamic. So there might be this subtle inability to stabilize what you're doing. So this is how we test for it in the VOMs. I'm talking about the vestibular part of the VOMs, or vestibular function first. Our VOMs is actually, we test the visual items first, so I'm going a little out of order. But people always want to know, well, what do we actually do in the VOMs? So if you want to play the first one, you can have the volume low. So I'm looking at VOR. And that's a metronome going on in the background at 180 beats per minute, and I'm having my patient just focus on something and moving their head quickly. It's an incredibly quick and easy screen to do, but if you have a patient that's come into your office and you haven't done something provocative to see if they have this issue, they may not even realize that it's there. Similarly, vertical is done the same way if you want to just show this the second slide.
The same thing vertically, so you're going to
So you focus on a target and then you just do it a quick 180 beats per minute, about 10 repetitions. So it's fast. And you're asking your patients about whether this bothers them to do it. Not just briefly bothers them, but do they have lingering symptoms after doing that? Again, if you don't look, you're not going to know. And again, there's no substitute. If you don't have an intact and well-functioning vestibulo-ocular system, if you're very quiet, sitting at home and resting, you're not going to notice it. As soon as, though, you start to participate in daily activities, you start to unload the dishwasher or move at normal speeds, or you start to run, or you start to participate in sport, that's where it's going to come out. And it may come out subtly as that you just don't feel your performance is as good as it should be, or that you just feel a little off doing these things. So again, it's very important. And the reason you use this system is because it's a very fast-acting reflex. It's the fastest initiating reflex in the body. So you can initiate the vestibulo-ocular reflex so quickly that no other eye movements can really take up the slack for it. So if you want to play this video, and let's go back to this hurling play, and it's going to play in slow motion in a moment. But if you watch him as he's going to the goal, I want you to notice what you're seeing as he's scanning. Okay, do you see what happens there? He's scanning. He turns his head quickly, and then scores the goal. So without a good vestibulo-ocular reflex, you can't run and turn your head. You probably can't run and still focus on the ball also, but you certainly can't run and turn your head. So again, congratulations on an excellent vestibulo-ocular reflex system to that guy. So what do we do if somebody does have impairment? Well, again, we don't sit and rest them. We can't do that. However, I can't have them do what that athlete was doing either. We start with activities that force you to do those functions. So you do activities where you're focusing and moving your head. So if you play the top video, this would be a very basic beginning type of exercise. Somebody that's very sensitive early on, who is having issues with this vestibulo-ocular reflex. And then if you could play the second video, and then you start moving it into way more complex activities where, they're in a busy environment, lots of noise, they're moving back and forth, looking at something complex. And there's lots of ways to do these things creatively, but that's kind of the idea of this training. And it's extremely effective, and there's a lot of good literature that shows that that's the case. So let's go into the second vestibular problem that we see quite often, and this is called visual motion sensitivity. And while the vestibulo-ocular reflex problems that people have certainly happen quite a bit, they're actually fairly easy to rehabilitate. When patients have visual motion sensitivity problems, this takes up way more of my time and energy and the patient's time and energy. This one's much harder to rehabilitate, but it's also much more of a problem in daily functioning if you don't rehabilitate it. So the way I describe visual motion sensitivity to people is I usually put up something horrible like a pattern like this, which I'm sure all of you love looking at now for the past several seconds that I've been rambling. And it makes you feel a little uncomfortable to look at that, right? You have this sensation that you're potentially moving because everything you look at is moving, everything else in the background is moving, right? That's what visual motion sensitivity feels like to people all the time. They have this feeling of discomfort. Now, it's potentiated because usually then what happens is if you sit and stare at this for very long, some of you might also notice that you start to feel a little anxious, a little uncomfortable, maybe a little nauseated. So you see those kind of overlays that start to occur with it. But basically, in any busy visual environment, patients are over-influenced by that, and there's this abnormal central processing of visual environment. So again, these are the patients who are going to notice that when they go into a supermarket or in the busy school hallways or wherever there's a crowded social environment that they become uncomfortable. Heights can be a problem, tunnels, bridges, things of that nature. And again, you often see then secondary symptoms like anxiety or avoidance tendencies, because, you know, I don't know about you, but if something bothers me a lot, I'm going to tend to just not do it, right? And that's what we see. So how we test for visual motion sensitivity in the VOMs, again, is very quick, very easy. We have the patients stand in whatever part of the clinic that there's as much background as possible. And then if you want to play the video, again, we use a metronome. We time it to 50 beats per minute so that we're getting a lot of visual flow behind the patient. Back and forth about 5 times. If I had a patient that I was concerned about balance, I would have them stand with their back to a table or a wall. And then after they're done doing that task, you wait a few seconds and ask, okay, what do you feel now? And you ask about symptoms. For all of us that do this, you might feel slightly dizzy once you stop immediately, just as if you had gotten off a ride. But within a few seconds, that goes away. In patients that have visual motion sensitivity issues, first of all, it triggers a high degree of symptoms, and they linger. They linger, and then some patients actually can't even really, they do 1 or 2 repetitions, and immediately they feel just horrible. And you know you've hit exactly what their problem is. So again, very quick test. So again, how it may affect you in sports is if you're on pitch with a lot of, you know, a team of a lot of other children or a lot of other players, just that involvement of kids moving around you, or if you're here at Croke Park and you have a big stadium full of people, this would be incredibly difficult to work through. So again, we talked about this, but if somebody has this particular problem in the vestibular system, visual motion sensitivity, we're almost always looking for other problems such as migraines or mood problems, because they often go hand in hand. And I think Mickey talked about this. There's a lot of circuitry in the brain that is shared among these systems. So often we see that there's this kind of driving effect among all 3 of them. And we certainly look at intervening in all of those areas with a combination of therapies, behavioral management, and medication as well. For training, again, we don't just sit and rest these people. We can't do that. We also, do have to be careful about how we train this, and it takes quite a bit of skill and intuition in how to do this, because as you can imagine, if you throw somebody too far into a situation where they're going to experience symptoms, it's going to create an anxiety response or create a migraine, and that's not very helpful. So you have to dose it in the right way. The large picture is a research tool. We call this our virtual reality cave at the University of Pittsburgh. And what that is, it's a virtual reality grocery store. The patient is on a treadmill, and that's a kind of the handle of a shopping cart. But what's neat is that we can manipulate the walls and the grocery aisles to be busier or quieter, or have the patient do tasks as they're virtually walking through the grocery store. Now, this is, of course, in our research lab. But if you play the top video, there are plenty of other things that we do clinically. So just by using things like busy backgrounds in your environment or your clinical environment can be helpful. Go ahead to the second one. I'll also sometimes, you can turn the volume down on those. So we do actually use a disco ball at times. I have a disco ball in all of my clinics. And the reason for that is not because we're partying like Saturday Night Live. We are, although it might be more interesting, but if you can imagine, a disco ball does create visual motion around you and in a 3-dimensional way. So sometimes simulating that in patients that are ready for it can be extremely effective, and sometimes I'll even have my patients get one for home. And then the last one is, again, you can say what you want about YouTube, but there are a lot of YouTube videos out there that are point of view videos. And this particular one, as well as plenty of others, take people virtually through busy places. This is, I think, the Latin Quarter in Paris. And they're out there for us to use. And, it's not just what I do in my clinic. It's what patients do and exposed to on a daily basis. So I can virtually give them practice if I pick things that are pertinent to them. So go ahead and move on. So those are just some ideas of things that we may do to treat this. From a balance impairment standpoint, again, one of the other issues that you may see, we usually see problems with this concept of sensory organization, which is using a combination of your eyes, your ears, your inner ears, and your touch sensation to keep balance. And what we find is after a concussion, patients really have difficulty maintaining their balance when a lot of these systems are minimized. So when you have to use your vestibular system and you can't use your eyes and you can't use your touch, patients have problems. So this is an area that's been studied for quite a while, and there are some great tests that are done and have been developed for looking at balance after a concussion. The first one is this clinical dynamic posturography, which is, I think, it's about $150,000. We don't use this with everybody, but we use different types of clinical tests. This is the BESS test, BESS, which is Balance Error Scoring System, which was developed for athletes, as well as this clinical test for sensory interaction and balance. And basically, in all of these tests, you have to have patients manipulate what they're doing visually as well as manipulate what they're standing on so that you can assess balance under different conditions. To treat balance problems, you have to change the surface that people are standing on, and you have to change what they're doing visually. And that's the key. So this would be a progression from easier to harder in somebody who had a type of a balance problem after concussion. You have to manipulate cognitive distraction as well. But again, it's not, balance recovers fairly quickly after concussion, so you have to be cautious that you don't overcall balance as being an indicator. So when balance is recovered, that's great, but that doesn't mean that they're recovered after a concussion. And then the last thing I'll talk about briefly is benign paroxysmal positional vertigo. How many of you are familiar with BPPV in the room? Many of you. So you know that it's a mechanical condition of the inner ear. So this is an actual inner ear problem that you see after a concussion, where the small crystals in the utricle and the saccule, particularly in the utricle, get loose and they fall into the semicircular canals of the inner ear. So if you play the top video, you'll see how, and you're going to watch behind the plate the woman who is standing there and walking. I'll play again. So as you can see, obviously that woman could easily have a concussion, but you could also see how benign paroxysmal positional vertigo could happen after a concussion. And what we do is, we have ways to look for that. There are people that treat this know how to look at eye movement patterns and nystagmus patterns when you evaluate somebody to know where the crystals are loose and how you treat it, but you do a combination of repositioning maneuvers to fix that, which is nice. But it has to be identified. And this would be the one condition where patients really do complain of that spinning dizziness versus that kind of more generalized wavy dizziness. So what about the visual system? Certainly just as important as the vestibular system, and we know from some research that the visual system is involved in a significant number of concussions. Convergence insufficiency problems, which means that near vision, are you seeing things as single targets? Problems with pursuits and saccades we see at increased frequency. Problems with alignment in your eyes. So your eyes should be generally aligned evenly, or you should be able to overcome that alignment issue. Sometimes that becomes decompensated. And then accommodative problems. So are you seeing things blur as they get closer to you? All of those things are very common after a concussion. In our study, we found that somewhere between 30 and 40% of our patients in the early days after their injury had some involvement of the visual system. So let's talk about how that could be important in sports. So if you could play this video. Now, you have to tell me, I know that that's a hurley. I don't know what the ball is called, but as you watch him, what's the ball called? Yes, the ball. He is using incredible skill in his pursuits, his convergence, and his accommodation to be able to manage that as he is moving and balancing that on his hurley. There's no way with an impaired convergence or oculomotor system that you're going to be able to do that. So in the VOMs, we have a quick we have quick oculomotor screenings. So if you want to play this, again, we're looking at pursuits, saccades, and convergence. So we ask about symptoms before the test, and then you're going to just do pursuit movements very quickly, but in a very standardized way.
So just follow with your eyes, back and forth. We're going to go 1.5 feet each way, and we're going to do 2 cycles side to side, and then we're going to go vertically up and down. Same thing, 3 feet total, 1.5 foot up, 1.5 foot down. And then I'm going to ask, the second part is saccades. So saccades are rapid eye movements. We're going to use that same frame, and I'm going to hold my 2 targets like this, and I'm going to have Cindy move her eyes as quickly as she can from target to target, back and forth 10 times or 10 cycles. So I'm going to have you move your eyes as quickly as possible from right to left 10 times. Good. And then I ask about symptoms again. So Cindy, what's your headache? 0 to 10? 0. Dizziness, 0 to 10? 0. Nausea, 0 to 10? 0. Fogginess, 0 to 10? 0. Okay, and we do the exact same thing vertically. So again, up and down as quickly as you can, 10 cycles. Good. And then can you give me your symptoms now? So bring it in. And stop any point that it doubles. And if it doesn't double, touch it all the way to your nose. So let's imagine right there is where she reported double. So at that point, what I'm going to do is measure between the tip of her nose and the target, look at the centimeters there, and then
And you repeat that 3 times just to get an average. What happens is sometimes patients can do repetition number 1 very nicely, and then you start to see it break down. So that's why you do it 3 times, and you ask about symptoms. Again, we do the oculomotor items in the VOMs first, so this would actually be the first things, and then those other vestibular tests that I showed would be the last things. And that's the order. Again, it's very quick, and it's meant to be a screen, of course, so you're looking actually to over-identify patients. And then if you do see problems, then you refer to somebody to potentially look at it further and treat if needed, and to look at more evaluative components and actually the quality of the eye movements, because it isn't just about symptoms, it's about whether those movements are happening appropriately. So there is treatment for all of these oculomotor issues, again, evidence-based. There's good literature, particularly for convergence and accommodative problems, that therapy helps. Visual exercises can range from very low-tech to very high-tech computer-based systems. It depends on what's at your disposal. Sometimes high-degree problems, you can do prism lenses or adjustments, although we don't need to use them very often, especially if somebody doesn't have a big pre-existing problem, as well as potentially there might be medication or surgery needed. Again, that's extremely uncommon. But things to treat convergence and saccadic and pursuit problems would range from low-tech, like on the bottom. Maybe play the first video. So this is a simple pencil push-up exercise, which is not a very sophisticated exercise, and it certainly isn't the perfect exercise, but it's a great starting point for some of these problems. And then you can play the next one, and then you can kind of see on the board there's a lot of different visual activities, and a lot of these things, they're good things just out on the internet in general for binocular vision activities that you can find. And then, oops, go back. Sorry, I think I just went too far. And then the third one is I don't think I have a video on that one. That's a Brock string exercise, again, for convergence. But again, just you want to make sure that somebody that you can refer to has the skills to do some visual training with patients when you identify these problems. It can really change things, especially for people then and translating that into school and work activities. So again, in summary, these problems are more common than you think after a concussion. You can identify these problems quickly, easily, but you need to treat them and address them because typically they're not going to get better, at least not get better as quickly as they could on their own. So, thanks for your attention.